Good afternoon, but also good morning and good evening to many of us. It's our pleasure to welcome you to our second webinar in a new series of ITM alumni webinars featuring the ITM winners of the Prize for Global Research 2022. This prize is awarded yearly by the province of Antwerp to research projects of master after master students of ITM and other higher education institutes. Development relevance, quality, and originality of the master theses are key in the selection. Through this award, the province of Antwerp wants to stimulate research relating to the global research. In this second webinar, MPH alumnus and laureate Calvin Tonga from Cameroon will present his master thesis entitled How to Assess Health System Resilience, a Scoping Review. In the ITM alumni webinars, ITM alumni share their research findings and expertise on a specific dimension of global health. The main aim is to share research findings, expertise, and experiences on a specific topic within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now briefly explain some of the webinar practicalities. If you want to ask a question, you can use the Q&A option you will have below your screen. If you want to ask your question in live, you can raise your hand. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. You can, however, use the forum function in the online alumni platform to start a discussion on your questions left after this webinar. At the end of the webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM alumni platform. Our today's moderator is Bruno Marchal. Bruno joined the Department of Public Health at ITM in 2000 after working for 6 years in Kenya at district level. Bruno is professor and head of the Health Systems Unit and a co-director of the Master in Public Health, the MPH. He mainly works on strategic management of healthcare organizations and stewardship, urban health, and research methodologies for complex issues in health. Since 2013, Bruno is also a visiting researcher at the School of Public Health at the University of Western Cape. Bruno, the floor is yours.
Thank you very much, Charlotte. In fact, it's my great pleasure to very briefly introduce Calvin and to moderate his webinar. Calvin started the thesis work with me and Tine Verdonk also, looking at COVID-19 in Cameroon, and quite quickly went into the direction of health systems, the strength of health systems, and therefore resilience, and then resilience of health systems. And then quite quickly again found out that there are very few frameworks to assess the resilience of health system. And so in the last 6 months, no, let me be more correct, perhaps from January up to June, Calvin then really focused his attention on the scoping review. I'm quite happy that he's going to present the results. So I'm looking forward to your questions. And please, Calvin, it's yours now.
You're muted, Calvin. Sorry.
Thank you, Charlotte and Bruno, for this introduction, and greetings to all the participants online. My name is Tonga Calvin. I work with the Ministry of Public Health in Cameroon, and I'm going to share with you the results of the work I did on how to assess health system resilience. As Bruno said, this work is the scoping review. So my presentation will follow the plan that you can see on the screen. And to begin with let's first try to understand what is health system resilience. Commonly used definition is by Crook et al. That is the capacity of health actors, institution, and population to prepare for and effectively respond to crisis, maintain core functions when under a crisis, and learn from the crisis and reorganize whenever the conditions require it. But to have a deeper understanding, I would like us to go through some keywords in the expression health system resilience. There is health system, that is the organizations, people, and actions whose primary intent is to promote, restore, or maintain health. This is the WHO definition. Then about resilience. When we talk about resilience, we mainly talk about how systems respond to shock and restore or find new equilibrium, usually better than what they had at the beginning of the shock. And we have the stressor. The stressor is a change in the context. A stressor may be a crisis, that is a long-term event that affects the system. A shock that usually is acute by nature, or a stress that is something within the system that affects its functioning. So if we look at this graph that was developed by WHO to better understand what we're talking about, if we look at on the right, we'll see here that we can talk about the health system, and we are talking of capacity level. So the capacity may be low to above average. But if we take a normal functioning health system, we see that what may happen is either a stress in the system or a shock or crisis that affects the system. And what may be the consequence of this is that the resilience, the response of the health system may be a collapse, that they don't resist and the performance will drop. And as the performance drops, the system may collapse. The system may recover, but worse than before. The system may recover and get to the level pre-events, or the system may recover and get better than before, or ultimately the system may transform. So this is what the various levels of resilience in the system as described by WHO. So from this, we can see that only resilient health systems are in a position to protect human life and achieve positive health outcomes for all in their everyday functioning when we talk about the stress, or as well as during and after a shock, because they can recover and get to the pre-event states or even better or transform. Now, why do we pay interest to health system resilience? I would like to share with you this image, and we see that since the West Africa Ebola virus disease outbreak, there has been increased attention on resilience of health system. Why? If we read at this, the title of these publications, we can see, for example, that this outbreak in West Africa, in Liberia, for example, the health system collapsed with the spread of Ebola. And we see that not only in Liberia, but in the countries in West Africa that were affected by the Ebola crisis. Not far from us, we have the ongoing COVID-19 pandemic that has affected health systems. We remember what happened in Spain and in many places like in Brazil, illustrated by this article. And now we also have the war in Ukraine, and more articles are talking about the vulnerability of health care in this conflict, or the vulnerability of the health system, or the impact of the war on the functioning of the health system. So since the 2014 Ebola viral disease, there have been repeated calls from WHO as well as the health system and policy research to look into health system resilience. And with the COVID-19 pandemic, I was interested to know how the country reacted, how resilient Cameroon had been to this epidemiological shock. But I was faced by methodological issues because we didn't have like a common framework or even common understanding on what resilience is and how it can be assessed. So I asked myself, how can health system resilience be assessed? And this is very important, because if we can assess the resilience of the health system, we may identify the weak points of the health system and take necessary actions. But still, we have no common understanding on what health system resilience means or how it should be understood. And there is still debate on how this should be assessed. So this work came as a contribution towards how health system resilience can be assessed, and it was divided into three specific objectives. First, to describe assessing health system resilience and to summarize weaknesses and limitations of these various the identified approaches. We use the scoping review approach to this work. The scoping reviews are type of evidence synthesis that are relevant for mapping evidence on topics and for identifying emerging terms, theories, and sources, as well as knowledge and or evidence gaps. Is usually used when you have topics that are broad, when you don't have like a consensual approach to things. And that is why we chose this for our topic, because as we said previously, there is no common understanding of health system resilience or even how to go about assessing it. For our scoping review, we use the GBI updated guidance. And this is the most recent orientation on how to go about scoping review. And the research question was, according to the available literature, how can health system resilience be assessed? So we followed the steps that are recommended for scoping reviews. First, the identification of the research question that we presented down, then search of relevant literature. After that, the screening of identified literature. Then we went to data extraction, and finally, we did data collation. 3 reviewers participated to this work, and we benefited from the expertise of our coaches, namely Bruno Marshall and Tina Verdonk. The protocol of this study was published and is publicly available as recommended in the GBI updated guidance. So we found 868 records from our search strategies. And 27 selected were selected from scientific databases, 7 through website search and snowballing. So overall, we included 34 reports in our study, as is described in the Prisma flowchart that is on the screen. So what did we find? First, 21 of our studies were case studies. 12 were about epidemiological search, epidemiological shocks. And we observed that usually we have increased number of reports after shocks. For example, if we see this period, 2016 to 2017, there is increase. And this comes after the Ebola viral disease outbreak in West Africa. And we have this second part, 2020 to 2022, which comes which is in reaction of the COVID-19 outbreak. The records that we included in our studies covered 103 countries, and most of this record, 13 of this record, proposed an assessment approach to health system resilience. 16 assessed health system resilience, and 5 were both proposed and tested the approach that they propose for assessing health system resilience. So in relation with the first objective of this study about the definition and conceptual basis supporting the assessment of health system resilience, we found that there is an evolution in the core elements in definitions of health system resilience. As we said, the definition is not a common definition, is not, there is no common agreement on the definition. So we divided our study on 3 periods: 2012, 2015, 2016, 2019, 2020, 2022. And what did we observe? In this first period, we have core terms like absorb, maintain, mitigate, prevent, protect, recover, reorganize, respond, and sustain. Then during the 2016-2019 period, we had new elements coming in like adapt, learn, prepare, transform. And finally, in the 2020-2022 period, we have like anticipate, foresee, support people. Whereas, as from 2016-2019, some core elements like prevent, protect, protect were deleted from the definition of health system resilience. So we have like the second period, 2016-2019, which is which focuses on the transformative dimension of resilience, whereas the third period focuses on the vulnerability reduction. From this, we see that there is a diversity in the definition of health system resilience, and there's so far no consensus on how to define health system resilience. So authors will develop, adopt, or adjust the definition based on their own understanding of the concept or the purpose of their work. So the concept of health system resilience still lack clarity, and Turen et al. Concluded to lack of conceptual maturity. The other thing is that there have been researchers in other fields, mainly developmental field, where people have worked on resilience, community resilience, resilience to hunger, resilience, urban resilience, and other. And in this domain, the resilience concept have been in use for more time than in the health domain. But we see that in the health system or the health policy domain, few authors take into consideration these frameworks from other disciplines that we consider to be a weakness. Now, about the approaches for assessing health system resilience, we identified three main approaches. First, the system mapping approach. Second, the capacity-based approach. And third, the strategy-based approach. Concerning the system mapping approach, it is supported by the WHO Health System Building Blocks framework, and it focuses on core health system function. We consider it to be a static dimension of the health system resilience assessment because we just look at what is existing within the system as as capacities in alignment with the WHO building block. It is thus an indirect assessment based on resilience needs or on resilience effects. The capacity-based approach is based on the Crook et al. Resilient Health System Framework. Here, the focus is on inherent resilience capacity as defined at Crook et al., and we consider it to be a dynamic dimension of health system resilience assessment. It looks at elements accounting for each of the capacity described by Crook et al. In 2015. It is a more direct way of assessing health system resilience, looking into strengths and weaknesses of each of the capacity. And now we have the strategy-based approach, which is based on this everyday health system resilience framework by Kagwanja et al., but also take into consideration the Branchet et al. Framework on the dimension of resilience governance. It focuses on resilience strategies. We also consider it a dynamic dimension of health system resilience assessment. And it looks into steps of resilience, that is how resilience is developed in the system. And we also consider it like a direct assessment of resilience process. So we also observe an evolution in the use of the various approaches. In the first period, that is 2012-2015, only two approaches were used, that the system mapping approach and strategy-based approach. Then in 2016, from 2016-2019, the capacity-based approach came in. And from 2020-2022, we start observing the use of a mix of approaches. But if we look the total, we see that the system mapping approach is the most used approach. This approach is based on the WHO building blocks. And this is may be explained by the fact that it is this building block is being used in the daily activities in health system for monitoring and evaluation, and it is in alignment with monitoring and evaluation frameworks. So it enables people to use data that are routinely collected in the system to perform the assessment. Whereas for strategy-based approach, you need to do so, to get into the system, to collect information, mostly qualitative and also quantitative information to assess the strengths and weaknesses in each capacities. And for strategy-based approaches, you need to be embedded in the system, to work with people in the system over a long period to see how the resilience strategies unfold when the system is confronted with a shock. which makes it cumbersome, time-consuming, and many people will not go towards that way. What are the weaknesses and limitations of the identified approaches? For the system mapping approach, the first weakness is the data availability. Remember, we just said it is based on the WHO 6 building block, and it uses routinely available collected data. And there may be problem with data availability where data are not correctly collected. Also, you have data reliability. We know the problem with routine administrative data about accuracy, timeliness, completeness, that may make the data not reliable enough to draw a sound conclusion. We also have the fact that this assessment is blind to the process of achieving resilience. We can say, okay, the system has maintained its level of performance, but what in the system enabled this, we cannot tell. And finally, this approach doesn't account for complexity in the whole system. Now, the strategy-based approach has a credibility issue because, as I told you, the researcher should be embedded in the system. He works within the system, and at a moment, he is an actor of the resilience within the system. So critics are asking how this person can be a neutral or an objective researcher to assess the resilience in a system which is his own system or the system he is part of. And for all assessment approaches, we should keep in mind that they are just snapshots at a point of time, because the shock system has a dynamic and it is permanent in a dynamic equilibrium. So with time, things change, the nature of the shock or the nature of the system or the type of reaction may change, and the results we found may change with these changes in the shock system equilibrium. We also have the failure to consider non-shock parameters that may affect the resilience of our system, external issues that may affect the resilience of the whole system. So it's not only about the shock and the system, there may also be other parameters that affect the system, and the shock, there may be many shocks at the same time, and this should be taken into consideration. So from our scoping review, we can conclude that there have been growing interest for the assessment of our system, but there is still no agreed and validated assessment approach. We could identify 3 assessment approaches, namely the system mapping, the capacity-based, and the strategy-based approach, but none of these approaches give a full picture of resilience. Thus, the use of mixed approaches that we saw as from 2020, and that may give better picture of the resilience of the health system. But we need further testing and learning of these approaches. So from the findings of these studies, we came out with a proposed integrated framework that goes from the health system as we know with the various components. And we can see here that we have these building blocks of WHO, the leadership and governance, the information system, financing, infrastructures and logistics, medical products, vaccines, health workshop. And this, we said, these are resilience prerequisites. The system has this. It is available in the system, and this is where where we go from. So when the system is confronted with a shock, when there is a shock to the health system, people in the leadership and governance position will use the capacities, that is the capacities in the system, that's the resilience prerequisite, as well as their management capacities. They will also use the resilience capacity in the system to develop and implement, to select and implement appropriate resilience strategies. That is, for example, anticipation, preparation, absorption, learning, adaptation, transformation, to enable the system to continue to deliver healthcare to the population and to protect the population from evil effects of the shock. So this integrated framework situates each of the 3 approaches and their use. So we have the system mapping, that is the prerequisite for resilience. We have the health system, the capacity-based approach that focuses on the resilience capacities within the system. And we have the strategy-based approach that looks into the resilience strategies that are selected and implemented by the people in the leadership and governance of the health system. And we now have that all approaches may look at the output, the outcome, and the impact of the health system on the health of the population. So some key recommendations to the health policy, health system and policy research community is first, that further research should be done into the factors that shape resilience of a health system. They should continue to test the identified assessment approaches separately or in combination. As we saw, there is use of mixed method. They should define and validate a toolkit with specific packages for frequent scenario based on 3 main parameters, namely the context, the type of shock, and the phase of the shock. And they should define the optimal frequency and circumstances for the assessment of various levels of the health system resilience. And finally, they should work on developing and validating an integrative meta framework for health system resilience. I want to acknowledge the participation of Madame Ateba Olivia, Dr. Brice Edjoa, Tina Verdonk, and Bruno Marshall to this work that I presented today. Thank you very much for your keen attention.
Thank you, Calvin, for a very nice and well-structured presentation. I see a number of questions coming up, and perhaps we can start with the first one, which is about shocks and the health system. So you've been looking at how particular shocks affect the health system. The question is, you refer also to non-shocks and non-health system related factors that affect resilience. Could you elaborate a bit on these non-health system factors or non-shock factors that affect resilience?
Yes, thank you very much, Bruno. Usually when we talk about resilience, we look at shock that are acute events like COVID or like a war or like a storm or other events that are acute and have a huge impact on the system. But there are, for example, other events that are within the system, like if there is the change of people in the system may affect the output of the system. We also have, like, if you have a sort of shocks, like a reduction in the inputs in the system, like financing and other things, they may also affect the way the system, the output of the system, and there will be need for the system to develop resilience to overcome the situation. We now have non-shock parameters, the non-stressor to the system. And these non-stressors are, for example, what is the situation of this health system before the shock happens? Because the health system is in an environment, is embedded in an environment, and it's affected by the environment as well as the system affects the environment. So at times we fail to consider the situation in which the system is functioning. Let's take a country, for example, we have COVID-19, but by the time COVID-19 happens, you have a country that is a post-conflict context. So this is a non-shock parameters because we are looking at the shock, which is COVID, but this is a parameter that affects the way the health system may react, may respond to the shock that we are looking at, like COVID. And we think that in assessing the resilience of a health system to a shock, we should take these other parameters into consideration before saying whether the health system is really a resilient health system or not. So we should take contextual issues into consideration. Other aspects, for example, is the people in the governance, they need like the support from external elements from the system. For example, you have other government and entities that may be involved in the response by the health system. Now, the way these other entities are responsive to the needs of this. And this is embedded this is a result of the administrative arrangement in this context. They may really affect the way the system responds to the shock. And this should also be taken into consideration, not just looking at people in the health system, but extending to the context in which the health system is functioning. Thank you.
And I think, in fact, in your framework at the end of the presentation, on the left-hand side, when you talk about the mapping approaches, is basically about what are, in fact, these pre-existing conditions that allow systems to be resilient or not. And we can perhaps go into that later on. But I also have a question that is related to this from Elizabeth Irungu, also one of our alumni, which is about the differences in organization of health systems as perhaps a context factor, if you want, or a prerequisite to resilience, and the difference between Francophone and Anglophone countries, the colonial legacy, and how far the old historical evolution of your systems and the difference between them may affect current capacities for resilience.
I agree with her. Yeah, I agree with her that historical issue, historical legacy, the administrative arrangements in the country may also affect the way the health system may respond, because the health system is not a standalone. It evolves in this context and needs inputs from the environment to be able to respond to the shock.
Yeah. All right. Then perhaps a question about the definitions of health system resilience. It's a question from Lucio Bain, which is about, okay, I was wondering if you were comforted from your findings with the operational definition of health system resilience. So is there a need to improve that definition conceptually? Do you feel comfortable with the definitions which exist? Okay, you already, of course, said that there are multiple definitions out there and there's no one that is perfect. So one question about, okay, which kind of definitions would you prefer? Second, what about indicators to map and measure health system resilience?
Thanks for the question. Yes, we've observed over time from this scoping review that there is change. The definition is getting enriched, but there is also deletion of some core elements. We saw someone like protect that was left aside since the 2016. But what we really observe now is we are going towards more integrative definition, and the latest one that is from Rogers et al., and that is used by the European Commission, the health system policy research experts from the European Commission, is really integrative. They define the health system resilience like the capacity of the health system to proactively foresee, absorb, adapt to shock and structural change in a way that allows it to, one, sustain required operation, two, resume optimal performance as quickly as possible, three, transform its structure and function to strengthen the system, and possibly four, reduce its vulnerability to similar shock and structural changes in the future. So we are going towards definition that integrate most of the core elements into one definition, and I think this is the way forward, so that we take all the aspects of resilience into consideration. Yeah, now coming to the indicators, from the fact that we still don't have conceptual maturity, the concept itself is still being discussed, and we saw that there are three different approaches, main assessment approaches. Each approach goes on each approach develops tools according to the conceptual framework. So if you take, for example, the system mapping approach, it will be like financing, how well is the system financed, how well is the system staffed, how well organized are people in the governance, what are their capacities, how is the information systems and things like that. But if you take the capacity-based approach, you will look into each capacities and will collect information for that. So there are many tools, and even for the capacity-based approaches, people are still proposing tools, more comprehensive tools to look at it. So we think this is a field that is in evolution, and tools will continue to evolve. And what we propose at the end as one recommendation is to come up with an integrated meta framework that will take all these dimensions into consideration, and maybe we'll now have comprehensive tools that may maybe not look in all key details, but will help to have a full picture of what is the resilience of the health system that is assessed.
Yep. So that's already kind of an answer also to Orawan, who is working or will work on resilience of local health systems in Thailand, and specifically how multiple shocks affect local health systems. And she was also asking about examples of indicators. I think, in fact, I would like to add perhaps a bit to your comment in the sense that given that we don't really have a kind of a uniform, and perhaps we will never have a consensual definition of resilience, because it is a socially constructed concept, of course. It may be not that easy to come to measurable indicators and kind of checklist approaches for this kind of a concept. And I think the second main issue, which you also talked about, is what are these theoretical underpinnings, what are the concepts, but also what is the knowledge that informs all of these different frameworks that are out there. They remain quite descriptive. They seem to be logically developed, but the real causal underpinnings of these frameworks is really not that clear yet. And I think that's where a lot of the next research should happen. A question that relates to the framework, okay, where is that question? I think it was a question about the WHO or other frameworks that look at the operational frameworks of WHO for climate resilient health systems, and they include stress specific components like surveillance and early warning systems, emergency preparedness. The question is it possible to use such frameworks for climate resilient health systems to other stress resilience, pandemic resilience, instead of the WHO building block model?
Yeah, to answer to this question, I would like to share again my screen on the framework, and we will look at it and see. Let me share this. Yeah. Yes. So concerning this aspect of the WHO framework or resilience to climate change, what the participant mentioned, comes into the information system, in fact, and it also relates to the awareness of the system. So in the resilience capacity, we assess how aware is the system, and that is why we use the early warning system to be able to identify early signs of a problem in the system and to know how to organize. And this is based on the information system. So in the early warning system, for example, we see that there is surveillance system. We collect data from the field. We do rapid analysis to check whether there is a peak. Can we see, is there an outbreak, and how we do about this? So this in the WHO framework is the information system. And people in the governance use this information to take decision. Now, in the capacity-based approach, we look at the awareness of the system. Are you aware of what is happening out there? Do you have elements? Do you collect the information to take timely decision and to select the type of strategy that is resilience strategy to be implemented? So all these go together, and that is why we think these three approaches, if we put them together, it helps us to have a comprehensive view of how resilient is the health system. And what we do in the daily, in the surveillance system, for example, is maybe I didn't say it. In the 2012-2014, for example, most of the resilience work were inspired by the global health security agenda, and the issues like surveillance were highly taken into consideration in this information system. And if you go back to the tools like the joint external evaluation of health security in country, you will see an aspect on the detection, and this detection is about awareness, it is about information systems.
Yep. No, I think it's also speaking a bit to the question, resilience for what? Resilience as a goal or as a means? The resilience as a goal, of course, is not what we want. The resilience should serve a particular thing. That's a bit related to first question on this topic from Karina Kielman, one of our colleagues here at ITM, which is basically critically looking at resilience. Is it always a positive thing? And then referring back to the thing, yeah, you know that there is this tendency to define resilience as bouncing back to the previous condition of a system, whereas a badly organized system that rebounds back to being badly organized is not what you want to achieve, of course. So what are your comments on that?
Yes, resilience resilience always a good thing, and that is one thing that was tackled in the evolution of the definition of resilience. If you look in the final words of the definition, is always like transform to a better status, because we think we should be aware that resilience, the concept of resilience, is borrowed from other disciplines, and first discipline were like in hard science, like physics and engineering. And here the resilience is the resilience of materials. So there is nothing like getting back to a better or going to a better status. Is getting back to the previous status. But when it comes to social science and public health, we want to go beyond just the previous status. We want a better status because we want to learn from what happened and to use this knowledge to improve on the system. So in the definition we introduce is taken into consideration. So it's not resilience like bouncing back to the previous status in our field, is to going to when needed, is to transform to a better status. Now, is resilience always a good thing? No. The answer is clearly no. Resilience is not always a good thing, and that is why we should look at what the resilience serves for. For example, if people are living under hardship and they become resilient, that is, there is no reaction, they adapt to this, they have this capacity to accept the hardship and to develop strategies to survive in this hardship. Yes, they are surviving, but they are not in a better status, and we cannot consider this as a good form of resilience because the hardship will still be there. So the good resilience, if we consider it from the social science and the public health aspect, will be for these people to speak out their grievances and to call for a change and to go into to obtain a better system that takes them into consideration and give them good living condition. So that is so if resilience is just to bounce back, no, it's not a good resilience.
I think that kind of makes a nice bridge to the next question, which is in fact about this very crucial phase. It's not about absorbing and mitigating and kind of short-term adoption or adaptations of the system. And these are the two very common focused on parts of resilience. It's also the transformation part, and it is quite crucial to get that organized. So the question from Manfredi, one of our current students, is taking into account these different strategies. Once the shock is absorbed and is being kind of adapted to, then when starts the transformation? Are these strategies overlapping, or should it be kind of sequential? And I would like to add as well, not so much when do we need to jump to the next step of transforming, but in what kind of conditions does it happen? How does it happen?
Yeah, there is one thing very crucial in this is first, in fact, I will say two things. First, the capacity of the people in the governance and leadership is very important. We think that the key of resilience lies within this group of people who have this capacity to use the available information to make decisions. But the second thing is learning. The system should be able to learn and to use the information even at early stage of the shock and to take the good decision. So as I was saying, transformation is a resilience strategy also. So it's not in all cases that you will need to transform, but people in the governance and leadership may judge that it is necessary to transform, to develop new skills, to change the organization, the way the system is organized, and to upgrade in the purpose of the objective of the system. So this is something they may decide on, and this may happen within the shock or after a shock. But this really lies in the hands of people in the governance and leadership, and it depends on how the shock unfolds or how the stress unfolds and how people think they can best react to this to keep the system alive and yield better outputs.
Yeah, I definitely agree with that. I think it's quite crucial to understand how that transformation comes about, the kind of conditions and the system capacities that you need. And basically, transforming also system capacities into people, and because a lot of the talk about health systems frameworks for resilience seem to kind of forget a bit about actors and people. They're hardly ever mentioned in this kind of literature. It's a literature that comes from engineering and from ecological systems where you don't have people actually. So I think that too is a point of attention to kind of bring back the actor perspective in the resilience discussions, which points again to one of the next questions, which is about, okay, how to consider the community as part of a factor of resilience, or rather, does community resilience contribute to health systems resilience? That's a reframing of one of the questions from Teresa Becher.
Yes, that's a good question. Although I didn't look really in the community resilience, I came across a review of this, and they were looking at what happened in England. How do they organize their community resilience? Yes, community resilience really contributes to health system resilience. First, we should know that the people are also part of the health system, and they are even they act like actors in the health system, like community health workers, like relays for health information and other aspects. And in some places, in fact, everywhere, they contribute financially to the health system through insurance or through direct payment to the health system. So all this is very important. Now, where people are really aware, for example, in England, communities are trained to react, how to react to a warning. If they say, okay, there is an earthquake, what do you do? Where do you go? Where are the places to the shelters and this? And they can do test simulation to react in case there is a problem. Such a community will not be as vulnerable as when another community that did not undergo this training, or which is not organized like that. So casualties will be reduced. And this is an output of the health system, because when we assess the health system in terms of morbidity, of mortality, and if you have a community, for example, they say, okay, there is COVID, stay indoors. Communities that are well organized and resilient, they know, okay, in case of crisis, these are the things that I have to have in my house, and I stay indoors for, it can help me stay indoors for 1 week or 2 weeks. That's also why in some places in Europe, people could stay indoors for months. But this was not feasible in other settings in the South, because people live on the daily, they live from day to day, and they really need to go out for looking for something for their family. So we see the difference in community resilience will impact the health system, the amplitude of the shock, the consequences of the shock, and the capacity of the health system to react. Because if the number of casualties is high, the health system is very fast overwhelmed, and it might collapse. Whereas in well-organized community, this may likely not happen at the same speed.
I agree, and I think we can also kind of give a kind of a different look at it, in the sense that it's not just that we want communities to be resilient in, say, to react to the shock. It's also people in health systems. I mean, health systems are social systems. It's about doctors and nurses, and it's people, not machines, and people are part of communities and families. And so resilience at individual level, resilience at family level, resilience at community level automatically is a foundation somehow of the resilience of a local health system or a hospital or an organization, I guess. And I think there's a lot of synergies to be developed there still, and it's one of the future research, not future, it's one of the research lines we're going to pursue with Sarah Simons also here at ITM. A question, let me look at in fact, a question about, if you talk about actors and people being part or central to this notion of resilience, what's the role of the educational system? The question is relatively brief. How does the educational system fit into the proposed framework? Perhaps I can reframe it to some extent by saying, okay, how do you prepare people to take up a role and responsibility or a capacity in making systems resilience? Or perhaps in another way, what is the role of competences of people, capacities, skills into building resilience as a prerequisite? Any ideas on that?
Yeah, I think this has to do with the preparation, and the preparation is a strategy of resilience. If you look at the the resilience strategies, you see that there is anticipation, there is preparation. So this preparation is not only about the commodities. We see, for example, in outbreak, we see they have like the prepositioning of commodities in case there is cholera, but you also need to train people to have the good reaction in case there is there is an outbreak. So this training in preparation of a shock is very important, and that is why in the framework also we said, in fact, people in the leadership and governance should have this awareness to anticipate, this awareness to use the resources in the system for resilience. And these resources is like building capacity, the capacities of people working in the system so that they are able to have the right reaction in case there is a shock. In many places now, for example, there is this simulation that they do for like Ebola outbreak. We do it quite often. And now with COVID, we are going into pandemic influenza preparation, and there is also planned to do like simulation so that people in the system are capable of reacting in the good way whenever a shock happens.
Yep. It's also, I mean, we had a discussion yesterday here in the MPH in the postgraduate course about COVID-19, local health systems and resilience to some extent. The paradox is somehow, how do you prepare a system, and therefore how do you prepare people to respond to a shock that you actually may not understand, to shocks, in fact, in the future that you cannot predict. And okay, you can think about existing shocks and historical kind of shocks, economic shocks, heat waves, floodings, earthquakes, natural disasters in general, let's say, political unrest or other things, but there might be shocks coming to us which we don't really understand yet, or even if they come and we know them, which we don't know really fully in terms of causes and effects. And so how do you prepare people for the unknown? I think that would be, for me, in fact, one of the core competences that we need to instill or to strengthen in our local health systems. It has to do, in fact, also with the governance arrangements, of course, that should be flexible, adaptive, agile, multi-level. There's a number of frameworks out there again, but you already pointed to, in fact, the importance of governance as a key determinant probably of the way we can prepare our systems to be resilient. Looking back at the questions which come up, okay, you get a lot of felicitations for your beautiful presentation and being in the hot seats and having to answer these difficult questions, but with good in-depth answers. So that's very nice, of course. The presentation will be shared afterwards as well as the recording, I think. And then again, a question on the indicators, which we covered. There are no checklists yet to do this kind of assessments of resilience, given the disagreements on how to do it and the definitions. Okay, question about, again, the link between resilience being defined as a component of health system performance. So that is one of the WHO toolkit on health system resilience, where they refer to, besides efficiency or public trust as indicators of health system performance, they mention also resilience. What do you feel about that kind of position of resilience in the overall discussion on performance?
Yeah, in fact, in that framework, I think I know the framework is talking about WHO presents resilience as an output of the health system. But I really don't agree with this WHO framework. Because if you look at the paper from Abimbola concerning resilience, it says robustness, it talks about strengths with robustness with adaptability. So when we look about the health system strengthening, and we look at this, how strong we want the health system to be. We also want to be the health system to be adaptive and to be able to respond to the shock in the right way. So to me, I think health system strengthening is part of resilience. It's just is also building the resilience of the health system rather than the reverse. So I look at the other way. But I think here the WHO wanted to grasp this concept of resilience and make the framework evolve, but keeping the health system strengthening project that is a core focus at WHO. But really, I look at the other way.
It refers again, yeah, thank you. It refers again to this whole discussion of resilience for what? And you know that as well that there are a few papers talking about equitable resilience. Resilience not just as bouncing back or recreating a system or even transforming it, but transforming it to be more pro-equity, pro-responsiveness, pro-inclusion. And I think these are in fact the things we would like to stress. Perhaps the last question, given the time, that is, can we talk a bit about the role of One Health in the health system resilience discussion?
Yes, yes. In fact, the One Health also is, we are talking here about epidemiological shocks. Yes, so the One Health is just also part of the health system resilience, and we are now talking about the planetary health. And so many things contribute or are determinants of our health, and even living with livestock, for example, is also influences the health of people. So this One Health approach is also a way of like preventing or reducing the impact of zoonosis. I think it's zoonotic diseases in mankind, and this also contributes to the resilience. So what I was saying is that the One Health approaches and we have like the NAPS, that's the National Action Plan for Health Security, that the country developed, is to protect people from the epidemiological shock. So we think it is also part of resilience in terms of preparing, in terms of anticipating, preparing, responding, transforming, because in all this process, people learn to talk to each other. So we don't want to have like health systems working in silos, human and animal health system, but we want them to work together. And this transformation is really happening with the One Health approach. And we think this is really part of building the resilience of the health system.
No, I agree. And I think we kind of welcome this attention for zoonosis, the interface between environment, people and pathogens, including animals, and the whole kind of ecological approach. But resilience goes beyond that, of course. It's more than just preparing for this kind of the next pandemics in terms of zoonosis. Perhaps the very last one, I'll just translate the question into a comment because we are going to run out of time. That's Orawan's question about how can we in fact make the discussion more fruitful, or how can we advance the discussion about dealing with uncertainty? And I think to me, that's a quite important issue here in the whole discussion, something that's under discussed yet in the literature, that is the unknown unknowns, and the fact that sometimes we will not understand what's happening, and yet we need to adapt to that. So it's not setting up 25 early warning systems for floodings and food problems and for I don't know what, but rather prepare the capacity of the system to deal with these uncertainties. And that's, I think, quite crucial. I'm going to give back the floor to Charlotte. I would like to thank Calvin, of course, for a very nice discussion, and also the participants for the questions.
Yes, that's what I want to do as well. Thanking Calvin for sharing his insights and presenting his master thesis findings. Also, Bruno, thank you very much for this interactive and enriching moderation of the webinar. Again, also thanks to Yves for his technical support. Also thanks to you participants for attending, and also for completing the survey, which will pop up on your screen. We would also like to invite you for our third upcoming alumni webinar of featuring one of the laureates of the Prize for Global Research. It is MSTAH alumna Claire Julie Akongo from Uganda, who will present her master thesis research findings on the 20th of October, again from 3 till 4 p.m. CEST. So please make sure you save the date and spread the word within your networks. Then it only remains me to say thank you, and stay safe and healthy, and looking forward seeing you again. Bye-bye. Thank you to all.
Thank you. Bye-bye.
Thank you.
Bye.